Hello, everybody, and welcome to another Healthcare World Series event. My name's Steve Gardner. I'm the Managing Director here at Healthcare World, and it's great to be back with another really interesting topical debate on what's happening in the world of global healthcare. Today, we'll be considering value-based healthcare. Value-based healthcare from the perspective of quality and the way in which the use of quality benchmarking and data allows us to create value-based healthcare models. It's a really interesting debate. It's a really interesting discussion, value-based healthcare, because at the end of the day, I think the basic concepts of payers, whether that be insurers or governments, paying for healthcare on the basis of an outcome as opposed to paying for a service for the doing of a thing is probably universally acknowledged to be the best way forward in terms of getting value from our healthcare spend globally. But it remains, by and large, tantalizingly out of reach. A great idea that has happened to some degree in some systems, and there are some good examples of it. I'm sure we'll explore a number of them today, but there's still a lot of work to be done. And it starts with this question of quality and outcome. What is it that we're paying for? And to join me in having that debate today, I have got, I have to say, a panel about which I am enormously excited. We have a lot of very, very large brains that are all going to make me look very, very silly. In no particular order, we have Professor Simon Jones, who is Professor of Population Health at New York University's Grossman School of Medicine. We have Dr. Reem Bunyan, who, as well as being Executive Director at the G20 Global Innovation Hub for Improving Value in Health, is also the CEO of Value in Health, the Saudi organisation that is advising across the kingdom as their healthcare system is transformed on how to implement value-based healthcare in Saudi. So we'll be able to give some practical examples of how this kind of thing is being implemented on the ground. We have Rob McGough, who by day is a partner at law firm Hill Dickinson, and by night dons a cape and spandex pants as the Vice President of the European Association of Value-Based Healthcare. Most of that statement is true. Probably the costume is not, but he's still a great authority on the subject. Kristen Geisler is a managing director at Barclay Research Group and has undertaken a number of engagements around helping US organizations understand value-based healthcare. Jane Brown is the CEO of Aetna Better Health of Kansas, a Medicaid organization with 130,000 members at the lower end of the income scale in the United States and a budget of $1.5 billion a year. Last but by no means least, Abele Anidi, who works with the G20 Innovation Hub and who is a great authority on all things healthcare, who I met in a taxi in Johannesburg about 3 years ago and have never quite been able to shake off. So a fantastic panel, a great group of individuals. And I want to start really by thinking about this question of quality. What do we mean when we talk about quality? And actually, how does the use of value-based healthcare help us to improve the quality of outcomes for our patients? And Reem, I'm going to come straight to you with that one, because that's, I'd imagine, the question that keeps you going in work every day of your life. Reem.
Hello, everyone, and thanks, Steve. Delighted to be here today and delighted to go first on this in grounding the concepts. So what is value and how does quality relate to value? On defining value, it's been a very important starting point for us, whether on a national front in the Kingdom of Saudi Arabia, building on the basic law of governance, building on the societal values, building on how the health sector is designed, the commitment to universal health coverage, the commitment to population health, in addition to going down to the personal and family level. And so we define that as outcomes that matter the most in relation to how much resources and investments we put to realize those outcomes. In the global front, this has come across in the conversations we've had at the G20, and we went back to the basic equation of outcomes in relation to resource allocation. I'd like to say one more thing on the relationship between quality and value. Quality largely focuses on health care And so when a service is offered to an individual, that's when we think about quality. And oftentimes in quality, there's a clear-cut good and a red line and a clear-cut bad, whereas value is the optimization of the outcome that we realize, and value addresses health beyond healthcare. And so I think this, starting the conversation with this is quite important, because sometimes a service is unnecessary. A service that's provided may be unnecessary. And oftentimes this is in procedures or interventions that are elective, like tonsillectomy, like braces, like knee replacement surgery, like a scan or a blood test. The classic example is vitamin D testing. And that takes us back to the remark that you made in the beginning on the shift in focus from activity to outcomes, whether clinical quality outcomes or prevention outcomes or other outcomes.
Because I think there's a point there to be made, isn't there? Which is that the difference between a value-based model and a volume-based model is that one allows you to focus on prevention as well as care, whereas traditional insurance models, traditional payer models focus on the idea that something's gone wrong and now we need to put it right. So actually, how you move from one to the other is really important. What are your thoughts on that?
Well, it's a fundamental shift. It's a paradigm shift. And, oftentimes when we have conversations with whether they're frontline providers, whether they're CEOs of hospitals or policymakers, we say that this is a paradigm shift. It's a fundamental shift in how we conceptualize. Other industries are by default focused on outcomes. When we book a ticket for vacation, when we book a hotel, or when we're looking for a restaurant, oftentimes as consumers, we're engaged in looking at how other consumers rated the service or rated this entity. In healthcare, I used to say that I used to call beneficiaries consumers, but it's even more complex, because the beneficiary should be involved in co-creating the plan, is often involved in implementing the care cycle, whether it's taking a pill every day or following the post-operative care plan, understanding that the time that the health system spends with the beneficiary and the family members and whoever's involved and engaged is a key element in realizing this thing that's called value.
So Jane, I'll come to you next, if I may, because from your point of view, and well, I think from the point of view of the topic in general, we talk about healthcare payers, or by and large, healthcare payers in most of the world are insurers, as technically you guys. Insurance, by its very nature, by its very definition, is the idea of management risk. So you've got a situation where something goes wrong, I go to my insurer puts it right. But that's not what we're seeking to do with value-based healthcare, with the idea of healthcare rather than sick care, is get away from being reactive. So how does that, or how would that work? Could that work for an insurer?
Absolutely. I think from the historic legacy approach that insurer would have taken is, you're right, it is risk management, it's utilization management, it's basically being almost like a big brother overseer to some of the clinical decisions that physicians are proposing and or delivering to our members or beneficiaries. But that's not the place where I want to be. I don't want to police providers, right? What I want is partnerships. And what I love about quality and value-based care is that this creates a whole language that we can all get behind, which is an outcome-based language relative to an individual's health. The fundamentals and the economics of being a payer or being an insurer is that you need healthy members. That's how you win. And in order to have healthy members and healthy outcomes, you need to have an alignment with your provider community, and you need to be very clear and intentional about what the desired quality outcomes are. So in the US, we have HEDIS and we have NCQA and we have some standardization, right, around what we consider to be critical quality measures, sort of coast to coast. But even within that, there are, I think, further opportunities to expand into, what are quality outcomes? What are we seeking to incentivize? How do we switch our reimbursement model and place our dollars or our investment into the outcomes piece of the puzzle versus into the how many services can be billed for on a particular claim form model? So the shift from fee for service to managed care, by its very nature, that paradigm shift, it is underpinned by value-based care as the vehicle to get us there. So at some point, what I anticipate and where we're going to go next is I expect 100% of my network to be in a value-based arrangement. There really shouldn't be a provider that I'm reimbursing who isn't in it for the same quality outcomes that I am.
Mm-hmm. Then, excuse me, I guess the question then becomes, if you're talking about the whole ecosystem, we're talking about wellness as well as healthcare, moving from a reactive system to a proactive system. How do you incentivize a payer to invest up front in looking at the wellness of their patients or their beneficiaries, and stopping them from getting sick in the first place? Where's the incentivization there?
Well, from a managed care perspective, we have a tremendous amount of incentive that we have developed with our regulatory partners. So, for example, I am a government contractor, right? And in the state of Kansas, I work for, essentially have a contract with the state of Kansas. The state of Kansas has very specific and prescriptive pay for performance measures that they incentivize payers to meet. These are worth many millions of dollars every single year. The difference between meeting those quality measures and not meeting those quality measures within a given year, that's really most of your margin. Because when we talk about managed care, we're talking about very tight margins. This is the underserved population. They are sick, and the reimbursement on them is not the same as it is on the commercial side. Having said all that, I think there is incentive there. And I also think that when we look at bending the cost curve and we talk about the medical loss ratio, right? When you have a healthier population, the reality is your MLR by definition is going to be better. That means that you get to keep more of the capitation payments as a payer that you receive. So I think the incentive that is all there. I think it's the challenges that we face isn't so much that there isn't enough incentive. I think that it's mostly the logistics of how. For example, we face challenges with, our population changes every month, every day even. We get a new daily eligibility file. So when you think about an ecosystem and following a member's care from cradle to grave, if that member is no longer your member, say the following month, and maybe you lose sight of them and you don't know if they ever got the preventative services that they really needed at that point in their life in order to make sure that they're healthier long term. So those are some of the types of challenges that we have, historically faced. And I think that there's also interoperability data challenges with providers that we face day in and day out, which sometimes make it harder for us to have a true picture and line of sight into the true health of a particular individual. But I also think that these things are, they're known issues. And I think that they're very sort of overcomable, a word. I think they are things that we can overcome together if we're very intentional and thoughtful about it. And so when I talk to providers today, I like upfront, if I enter an agreement with a provider, we're going to have discussions about outcomes and value-based arrangements. Like on day one, we're also going to talk about things like data access and how do I have access to their EMR? How do they have access to the data that I see about this individual? Because I see it from multiple different providers. And so I have line of sight and insights into things that they might not be aware of. So it's really just building that partnership. It's underpinned by trust. It's also supported by a regulatory framework that allows for the transfer and sharing of protected health information in a secure way. And ultimately, that value-based arrangement is what keeps us all sort of navigationally going in the right direction, which is an outcome-based direction.
So that's really interesting as well, because I mean, you're coming at this from the perspective of a state payer. Your competitors in the US market and across a lot of different countries, this will be similar, will be commercial organizations and commercial insurers who might look at things in a slightly different way. So, Kristen, I want to come to you on this point, because obviously you have experience across both the public and private payer. One of the issues that I've come across when discussing this issue of incentive, and particularly prevention, public health information, screening, etc., is that amongst private payers, there's often, or seems to be, a reticence to look at prevention, because they're looking at it from the point of view of, Jane talked about people moving in and out of her scheme. The private sector organisations come at this from the point of view, well, why should I pay for preventative care? Why should I pay for screening? Why should I pay for public health messaging or looking at diet or smoking cessation, when actually that person's going to move out of my network into somebody else's, and they're going to get the financial benefits that I don't get? What would you say to that?
You're hitting the nail on the head of some of the challenges that we're seeing in the US with exactly what you're saying, this short-term nature sometimes of the payer coverage. And I'd love to hear Jane's perspective on this too, because I'm sure you're dealing with that. If we think of our Medicare payer, which is paying for care 65 and older, by the time the patient's gotten to be 65, those prevention elements that could have been put in place earlier may or may not have been. So there's this often lack of alignment between what's happening earlier in life and later in life. And now there's a total cost of care burden, if you will, on later in life. I think what we're starting to see, though, is an alignment of some of those measures. Jane mentioned some of the HEDIS, NCQA. Some common themes are starting to be strung throughout what I would call the patient lifetime, or the person lifetime of their care. So we're moving very slowly towards this alignment where hopefully the same things are being measured across a lifespan, that then that prevention is lined up and stacked. So when the patient gets to that 65-year-old in the US, at least, Medicare will hopefully then be picking up a patient that's had these preventative services all along. Your very first question was, how does value-based drive quality in healthcare? And I think that is perhaps one of those opportunities where if we line these value-based services up for the whole lifetime, in the US at least, I read a stat recently for Epic, one of our large EMRs that I know has gone global. I think they said 40% of their patients that they have been now on Epic from birth. So it's really interesting. And while Epic isn't a value-based entity, when you think about now this concept of healthcare, value-based care starting at birth and stringing through now through commercial payers, perhaps state Medicaid payers, and then to Medicare, I'm optimistic that we're going to get to the point where we have that prevention lined up. Jane also mentioned, though, that interoperability issue and data sharing. I think that's perhaps one of the gaps, because we don't have that democratization, if you will, of data right now, at least in the US, where the data is very siloed. So the Medicare payer, for example, doesn't have access to that data for the patient earlier in life, or a population health organization perhaps doesn't have access to all of that data. So maybe that's where our opportunities lie in being able to have this seamless value-based care across the continuum of care of a patient.
So there's a couple of things on that I want to pick up on. I mean, the first one, and I love the optimism in what you've said there, but I do wonder whether it's optimistic, because at the end of the day, we're talking about commercially profit-driven insurance companies, yeah. And what you're saying there, ostensibly on the data sharing point, is it's a bit like getting Apple and Microsoft to share customer data, because they look at it as customer data, and they do look at it as, why should I share member information with another commercial insurer when essentially that is my customer base sitting right there. By the same token, if I can paraphrase what you were saying about the preventative care agenda, it felt to me like the idea there is actually, we get all the insurances companies in a room together, we knock their heads together and go, right, if you all invest in preventative care, then actually you all benefit, which is, of course, absolutely true. But are they really going to do that?
Jane, I'd love your perspective on that.
I think the answer is we don't have a choice. So I do think we do want to and have to do that. So right now, or in the past, perhaps, and I do think we're moving away from this, but you end up playing a game a little bit of hot potato, and it's like, who's going to end up with the hot potato when the hot potato costs you $1 million in the hospital?
Medicare, by the side of what Kristen was
not
saying.
A great game that I like to play personally. When you think about, risk and managing risk, the reality is the preventative care doesn't cost very much. And to be able to incentivize it with our provider community now, it's almost negligible when it comes to the downside of not having done it. So there's that piece. And I also think from a member experience piece, it's better as well, right? Because members do want to know that they need to go get an appointment. They do need to have updates about, their health. They do want to be informed consumers. Nobody wants to wake up and feel crummy every day or have any sort of aches and pains. And so I think it's just recognizing that directionally, people want to be healthy. Payers want happy members who are healthy. All payers want healthy members. I know it sounds simplistic, but I think at the same time, and by the way, one of the things that you'll see about my background is I have worked for multiple different payers. And I probably worked for the 3 or 4 biggest managed care carriers in the country at this point. And never from one carrier to another did I ever see there not be an interest and a motivation and a direction to get healthier members, right? So I think we're all there philosophically. I think where we probably have fallen down or maybe have an opportunity for the future is that democratization of data, that interoperability, those components, that infrastructure hasn't quite been there. There are states at the state level, you have these MMIS, these interoperability systems that have emerged for the Medicaid population. And so what you're having is like almost a federated view of all of that. I could see a world where CMS, for example, gets engaged and starts to create a unified system, bringing together all of those MMIS feeds and creates a more federal sort of data pool, for example. And that by the time you do get to a Medicare point in your life, eligibility 65 and over or whatever else, that there's this history of data that your new carrier can pull through and understand what you have had done, what you haven't had done, all of the notes and all of the valuable, clinical assessments all the way through that got you to the point where you are at that moment. So I think there's work to be done, but I also think that the foundation in terms of payers philosophically wanting to be a part of something greater and understanding that we have to give to get, I think that's already there.
I want to take this back to the Middle East and to Reem for a moment in terms of how these two particular issues, preventative care and public health and data sharing, come back into the Middle East market. I do also want to reassure Rob, Abele and Simon that I am coming to you shortly. So Rob, I want to give you a chance to kind of comment on value-based healthcare from a European point of view and Abele from a more global perspective. But before I do that, Reem, I want to come back to you because I've seen this certainly in the UAE, and obviously you've been working on this in Saudi. Dubai, for example, where public health and public health messaging and screening programs are so non-existent amongst commercial payers in a market which is purely commercial payers, that the Dubai Health Authority has spun out the Dubai Public Health Corporation because they've understood the need, or they've come up with the idea that there is a need for government to take control of the public health agenda. Equally, in Abu Dhabi, the establishment of Malafi as a health information exchange, collecting all of the healthcare data for every citizen of that emirate, regardless of what payer model they're on. And I know there are similar programs in Saudi, aren't there? So how does, from your point of view, this issue around public health, preventative care and data sharing work in Saudi and the Middle East?
I found it really interesting listening to Kristen and Jane. I'll start by saying that, the transformation of a private payer is from fee for service to value-based payment models, whereas the public payer is moving from perhaps bulk payments, at least in the Saudi health system, moving from bulk payments to risk-adjusted capitation. So the from to is somewhat different, and the alignment of incentives of all payers is something where the regulator has a role. In the Saudi story, it's a whole of system transformation that keeps in mind, transforming or moving to a high value health sector. This is a key top to bottom enabler of this to take place. Whether it's in, how services are designed, whether it's in including prevention and focus on funding preventive models, workplace wellness, school programs, etc. From that perspective, or whether it's from the data sharing perspective. The example we have nationally is the establishment or the beginnings of having a unified national health record, where there's a minimum data set that is in this exchange. It's called NAFIS, which is short for National, I should know it by heart, but it's a unified health exchange platform that the private sector, the private providers and payers are more engaged in it because of where they are in the journey, and their readiness to engage in this is higher. Whereas the public sector is going on a somewhat different journey, where the capabilities within the providers are being built, etc. The last part in this entire conversation is how the people are engaged in this. The ability of people in the population to understand how to engage with wellness and prevention programs, their health literacy. And I think that's something that's very local, whether it's in the Middle East, the differences between, Saudi Arabia and United Arab Emirates, or the differences between a Saudi individual and an American individual in their own setting, in their ability to understand and engage. I mean, as a frontline clinician, I can say there are huge differences between doing a clinic in the US and doing a clinic in Saudi Arabia. The conversations are totally different. In my practice in the US, it's a one-time engagement where I can have a conversation with a patient about their diagnosis and provide them with information, and that's it. Whereas in the Middle East, it's a two-time clinic encounter or a three-time clinic encounter, where you need to explain the first thing and then the second thing. And similarly, when there are campaigns to spread awareness on whether it's vaccination, now we're on the flu vaccine season, or other programs. So that's, the contribution from this region around the conversation so far.
National Platform for Health Insurance Exchange Services. I Googled it while you were speaking. But yeah, I mean, it's similar project to the one that's going on in Abu Dhabi with Malafi.
Yeah, and just the point on that, just to ensure that the listeners are, the point on that is that the regulator, the government is enforcing, engaging and populating that platform. And so that should enable us to, have a whole of system, high value health sector.
And that's the interesting difference, I think, between the two systems that we've examined so far in terms of US and Middle Eastern systems, is the level of government engagement and the level of government mandate. So, you've got that situation where the use and the health information exchange is mandated at state level. And you've got that sort of element, which is less so, I think, in the States. But I want to move on because Rob and Abele and Simon have been sitting very patiently for the first 30 minutes of this conversation. I hope you'll forgive us, gentlemen, because it's been a fantastic debate already. Rob, I want to come to you next, simply from the point of view, how does this relate to European health systems? Because again, we've got a very different payer models generally in the UK and most mainland European countries. What does value-based healthcare mean in a European context?
It means different things in terms of the different systems, as you identify, Steve. Really, I think it's different systems have different approaches to value and are at different stages of the value journey. And I think some of it obviously relates back to what Reeve's been talking around the Middle East. There are some areas, I would say, taking Wales as an example, there is a good, strong government drive towards prudent healthcare, towards the value principles. And so Wales is at a different position, I would say, to the rest of the United Kingdom, because you've got that regulatory government support to try and drive value-based principles forward. And I think that does make a huge difference. And we've seen that really in terms of in a number of countries that we've worked in. Netherlands is another good example. The Nordic countries, lots of those have embraced value-based approaches. And interestingly, in the Netherlands, going back to your point, the earlier point that Kristen and Jane were talking about around the insurers, I've seen examples in the Netherlands where the insurers have been driving value-based approaches. They've been pulling the providers in together and asking the question around stroke services. We need to redesign this. The cost is becoming too high. And I think that's where, actually going back to some of the points that Jane and Kristen were making earlier, I think in the insurers' engagement, I've had conversations with value advisors for insurers, both in the US and in Europe, and they can see the writing on the wall if they don't change, if they don't start to change and move towards this preventative model and start changing the dynamic. The premiums are increasing, the cost of healthcare is increasing, and ultimately it becomes a zero-sum game for insurers because the members can't afford the premiums if it keeps on moving in that direction. So actually, a number of insurers are looking at value-based approaches to try and drive that preventative agenda, and it's in their interests, I think, to do so. I think the other thing is, I think we're in a very different position in value-based healthcare than we were 5-6 years ago. I'm old enough to have been talking around some of the models when we were talking around contracting for outcomes and starting to look at some of the initial models that were coming through. When we had to actually have, we didn't have the data, we'd have to have outcome holidays for the first year or two of the contract before we could start measuring and start reimbursing people and incentivizing them according to the outcomes. And that dynamic has shifted very much. The technology has improved massively, which enables us to get the data in a much more almost real-time basis. And actually, I think that there's a realization, I think, in terms of some of the regulators, and I think we're seeing this, the Middle East, I think, is really pushing forward very, very quickly on this realm, and it's very dynamic and interesting to see. But even in the UK today, there are various announcements around prevention needing to change, needing to start shifting. They've been talking around it for 30 or 40 years, but the hope is that there will start to be more of a shift. Look at France. France are investing billions in terms of looking at value-based healthcare systems, looking at value-based procurement. Germany similarly is looking to do this. Across Europe, the different systems are all starting, I think, to realise that there needs to be a shift towards adopting the more outcome-based approach, which in itself will incentivize prevention. And going back to your original question as well, Steve, incentivizes the quality in the services that are coming through as well, because it's patient-related outcomes. So actually, if you're looking to measure that, that becomes really important. I mean, from a personal view as well, I mean, my personal interest obviously is from the legal side in terms of how you procure for this, how you contract for it, how you implement it. And I think this shift that's been talked through, Kristen, Jane and Reem have talked at the start, I think the mechanisms that you're talking around, the regulatory changes, the impact of the data that's coming through with that, mean that it becomes much easier to actually work with suppliers and providers on a value-based basis. And it is, I feel, really starting to gather up some momentum in Europe, I think, but Middle East, Reem, I think it's moving forward very quickly, and some of the US models, Blue Cross Blue Shield and others are doing some fantastic work around outcome measurement and how you incentivize your providers as well. So I think there's lots of really good international examples now, Steve, that you can see as to how this is starting to come together.
So I guess then, Abele, coming to you from a global point of view, looking at this as the global innovation hub, looking at this from a G20 perspective, and looking at some of the global challenges around healthcare. You were talking about the intent, the UN goal of universal health coverage for all. The issue that we have globally around the workforce crisis that's coming down the track, but some would say is actually already here. Is value-based healthcare actually not so much of a nice to have, a nice goal, but something that is absolutely essential if we're going to solve our global healthcare issues? What do you think?
Yeah, Steve, it's timely that you've invited me into the conversation at this point. It's been such a fruitful conversation. I actually want to build on a point that Rob just made around the growing crescendo and platform and conversation around value-based care. I mean, the Global Innovation Hub itself was born out of the most recent global health tragedy of the pandemic in 2020. And while we think about that as the most significant public health crisis in recent memory, it also served as fertile ground and fertile ground for a conversation around a needed paradigm shift. You're based in the UK, Steve. You can remember the fact that the NHS was actually born out of the wake of World War II. And sometimes a tragedy or an intense moment is a really fertile ground for people to rethink how health and different services should be delivered. So I think the hub was born out of the pandemic in 2020 when Dr. Reem was the chair actually of the health working group. And since then, it's been this really interesting conversation with our membership that includes representation from 18 of those G20 countries around how do we build for the future? How are we proactive versus responsive? And I think the fact that we have this front door access to governments, I mean, we've been talking about things from the private sector and the different perspectives, but from where we sit at the hub, our membership consists of representatives from these different governments who are sitting here and engaging with us and open to the idea of thinking differently, of planning differently. And as a result, we're able to kind of preach and bring this gospel of value for money and value for many that is actually resonating maybe in the first time. I mean, Dr. Reem's been on this journey for quite some time, but we're engaging with countries from all over the world. Yes, we're based in the Middle East, but we have done reports and engaged. We have a recent report that we did with Rifat Atunin, the Harvard Health Systems Innovation Lab, that built out, from our perspective, the 10 essential conditions for a high-value health system. And that includes in-depth case studies that spotlight recommendations and examples of how different countries are moving the needle. And I mean from Australia to Argentina to India to France to non-member G20 countries like Portugal and Singapore. So we're seeing a very encouraging and rising tide of the concept, and not just the theory, but the practical implications and benefits of value actually taking hold. And so from where we sit within the Secretariat, it's our job and our responsibility to ride that wave and ensuring that we're codifying those examples of what works, that we're spreading and facilitating opportunities for cross-learning. Part of the frame of this event is around benchmarking and the utility of benchmarking. And I think, that's actually one of the 10 essential conditions that we articulated. Performance benchmarking as being critically important, but also cross-country learning. How are we leveraging what is being tracked, the outcomes that are being tracked, and actually leveraging that to improve cross-country advancements in the delivery of health services? And I think Jane and Kristen touched on this too, this question of interoperability and data sharing. And the one thing that we've seen kind of coming out of the G20 conversation is this global initiative for digital health, or GUIDE, which some of you may be familiar with, which is the recognition of digital services and public digital infrastructure as being essential for the 21st century health system. How are we facilitating the means through which we collect, assess, evaluate, and leverage data in a more fluid and fast-paced way in nature? And so the WHO, PATH, other organizations are coming together to articulate the need for building out that digital public infrastructure as a means of actually facilitating that process. And I think, we just came, last but not least, I'll just make a final note here. We just had a closed session in Salvador. The G20 presidency is being hosted by Brazil this year. And so we had a closed session with our membership of G20 countries in Salvador in June and received a renewed mandate to focus and continue to move the needle on value-based healthcare, right? We had countries around the table tell us the different degrees in which they've made progress, but also restate that in the event and in preparation for the eventual next public health crisis, that we got a renewed mandate and focus to continue to preach the gospel and focus on value-based healthcare as a means of moving the needle and preparing health systems for the future threats that are around the corner.
And I think that's really crucial. And that mandate is important because at the end of the day, what that validates is pretty much what we've been talking about in the whole of the first half of this discussion, which is that in order for us to maximize the effect of our global spend on healthcare, in order to ensure that we shift from the reactive sick care model to a proactive healthcare model, the only way of doing that is to create value-based healthcare payment models. Otherwise, we're just going to keep fixing the roof every time, and then it rains and the roof's going to fall in again. And we end up, I mean, Rob brought up the fact that we've had a big announcement in the UK today. Aradazi has reported on the state of the NHS. Spoiler alert, it's broken, and what we need to do to fix it in the long term. Part of that was about creating preventative healthcare, which is essentially what value-based healthcare is all about. So I think we furiously agreed that value-based healthcare is a good idea, and I think it's important to do that. Let's focus the second half of the debate then on how we deliver value-based healthcare. And at this point, let's bring in our ace in the pack, our statistician in residence, Professor Simon Jones, because the first question that we've got to ask is, how do we measure value and how do we measure quality? So if you can unravel that one for us, then I think we're all sorted. Simon.
As a dodgy statistician who spends most of his time doing numbers, I'm sure some of my fellow panelists would be better to answer that. I think one of the things, can I just address partly the data sharing thing? As somebody who started in the United Kingdom and then moved to the United States, in the United Kingdom, we have, almost a cradle to grave data system. And yet, since I've moved to the US, I think I have seen far more innovative value-based healthcare. And that's largely because people in the US are prepared to take a risk, try something, and if it doesn't work, stop it, which is an attitude that is less common, I think, perhaps in the US. And I'm very happy for Rob to shoot me down as being insulting to my former country. The other thing that I find very interesting was data sharing. And I think everyone talked about the need of data sharing. Well, during COVID, I spent much of my time actually analysing COVID data. And the crisis of COVID meant that most hospitals in New York shared much more data than they normally would. And it meant that we were able to detect all sorts of issues and, of care and better ways of improving things. So we can share data. It needs a crisis to sometimes motivate us to do so. The indicators, I'm going to be slightly naughty and focus rather more on the benchmarking and the things, because that's what I do as a dodgy statistician. But one of the issues that we found when we've tried to introduce value-based healthcare to our system is that, there are all these initiatives that people talk about, care navigators, interventions in the emergency department, etc. And one of the issues we found is that the key point is, only one in 5 of those actually make a blind bit of difference in our healthcare system when we try them first time. And so we've actually set up in our healthcare system, a randomized control unit where we actually, we think this might reduce demand for emergency care. Well, okay, let's set up a randomized trial and let's actually test if it works. And if it doesn't work, let's stop it or refine it. And personally, I talk to colleagues of mine in the National Health Service. That approach is far more difficult, I think, to introduce for that. We could talk about the indicators and whether people talk about, per member, financial things like reduction in per member per month costs, or whether it's, process indicators like, number of people who have indulged in smoking cessation. I will leave other people better to do that. But I think one of the really important things is once you have those indicators to be able to benchmark them with other similar hospitals so you know you can do better. And a classic example, a couple of years ago, we found that our transfusion rate was way higher than we might have liked because of benchmarking. And we introduced trials and we actually reduced the amount of blood transfusions where they were perhaps less appropriate. I think I've completely sidestepped your question, Steve.
Well, I was going to focus you back on it because the key thing is this point around, okay, if you are creating a value-based payer model, you've got to work out what it is you're going to pay for. And at what point do you as the dodgy statistician in the room, your words, not mine, how do you actually work out what a quality outcome looks like? How do you turn that into a number against which you can make a payment? That's my key question.
So I'm very much in the provider space, and I think that question might be asked better by somebody in the insurance space. But certainly, for every single one of our initiatives, we identify a problem, we identify how to measure it. It might be a large number of repeat returns to the emergency department, of which we have, like many healthcare systems, a significant problem in that. I think, well, okay, let's try and work out how to do that. There are great tools, from logic models to whatever, to say, well, how can we actually address that? But I'm going to actually try and encourage one of our insurance people to talk more about what indicators they think are important, because by the time they get to me as, dare I say, the dodgy statistician, we have a project, we are keen to evaluate it, and I'm helping them evaluate it. I think perhaps you need the more strategic outlook than a dodgy statistician's one.
I think, Jane, that means that the ball has been very gently passed in your direction.
Fair enough. Fair enough. And as you asked the question, I instantly had my answers. So perhaps this is a good place to throw the ball. So quality, right? How do you measure it? What is our benchmark or target going to be? I think about it in a couple of buckets. The first bucket is, what is the NCQA number, percentile, like where are we relative to that national average? So what's nice about what NCQA does is they measure 50 some odd measures. They combine pools of payers based on the population that they serve. So you can have the HMOs or the PPOs, the commercial, the Medicare, whatever it is, the DSNPs, and you can essentially know how is your population faring relative to the national average for that population segment. So for me, I know that right now in America, for at least Medicaid, the combo 10, which is the 10 immunizations that you need by the age of 2, is really struggling. There's a lot of resistance to immunizations. Probably part of it is some of the political aspects of coming out of the COVID pandemic, and won't even go there. But the point is that number has been on a decrease in the past couple of years, and frighteningly so. Right now, I think the national cut point for the 50th percentile is around 30%. That kind of scares me, that maybe there is as many as 70% of the Medicaid pediatric population not getting all 10 immunizations that they need by the age of 2. So I know what the mean is, and my goal from a payer perspective is to exceed and beat it. I want to be a 5-star plan. In order to be a 5-star plan, you need to go ahead and hit those 50 some odd, HEDIS measures every single year. There are some other things that bake into a stars metric at the end, like survey results and caps and things, but HEDIS and your performance relative to those data sets is very, very vital. So that is very good because it is national and we're all on the same page about it, and every payer is kind of rowing in the same direction, which does create a sort of unifying synergy amongst us, right? Because we all want to try to incentivize ultimately some of the same measures, whether they're my member today and their member tomorrow, it doesn't really matter, because we all are worried about blood pressure right now, or combo 10 as it may be. So that's one bucket. And then the other bucket is when I think about value is like, what are the key drivers of cost? And I think, Simon, you actually, brought it in. It's the ER readmissions, right? It's the high utilizers. It's like, how do you find some of your sickest and unhealthiest pieces of your population, that top, say 1% or 2% that are probably contributing to 60, 70, even 80% of the overall cost? How do you incentivize your provider community, and how do you yourself identify those members within your population? And how do you deploy appropriate interventions in partnership with the providers in order to bend that cost curve? So if I have somebody that's gone into the ER 6 times this year, how is, like, on the 7th time when they're there, and let's say they go into Presbyterian Hospital, whatever, I want that hospital to help me create an intervention so that that individual doesn't come back for the 8th time. A lot of the times that they're entering that facility is not for true emergencies, right? It's a lack of primary care access or even urgent care access. It's like an ear infection, it's the flu, it's things that could be mitigated. So how do I incentivize my provider to essentially not want them to come back into their ER, even recognizing that it probably is a revenue driver for them? And I think you do that by creating some of these value-based agreements where you have shared savings, or a concept of shared savings. So, hey, next, on the 8th time, let's do this. Let's not have them come back on the 8th time. And when we avoid that cost on the 8th time, I'll give you 50%, okay, of what I saved. Like, that is the kind of thinking that we need. And those are the kind of benchmarks that we need to infuse into the system in order to really propel us down a path of, I guess, mutual profitability, right? There's a part of this that where we do need, the business to work. But in the long term, also, I think it does create for better health. It creates for better outcomes, and I think a healthier population.
So what I love about what you said there was that move from a perverse incentive towards a positive incentive, because you're going from a situation where, and you said it beautifully, as a provider, my incentive is I want them to come back 7, 8 times to the ER, because every time they come, I get paid again. Yeah. Every time I do a thing, I get some money. So, Kristen, I'm going to come to you on this one, because it seems to me that there's some mind-bogglingly big maths going on here, because you've got to think about every individual element of what's going on in the health system, what's going on in terms of treatment models, what's going on in terms of visits to GPs, consultations with specialists, operations, etc., etc.
Yeah.
How do we go from measuring how many times a thing was done to measuring how well a thing was done and what that meant to a patient? Only a tiny question for you there, Kristen.
It's a big one. And a lot of the work that we do is on the hospital side. So highest cost of care. So to Jane's point, high utilizers using high cost of care. The providers are incented to have those patients return to the organization many times. A lot of I would say most of the providers in the US at least have this blend of value-based and value-based and volume-based care. And the challenge there, as you say, how do we make that shift? So just sort of the history lesson, at least in the US, of quality measurement, we started on the process side. So we said, how often did you get a test that measured your heart function? And we sort of nailed that. We checked that box every time. The organizations checked that box. So the movement then was towards that outcome. Okay, did your patients die less from heart failure or heart attacks? Did you readmit patients less? And we've had this swing from process to outcome, but now that outcome is sort of confabulated with things like risk adjustment. And Simon can definitely talk to, I'm sure, some of the challenges in measuring those outcomes. And we're sort of swinging that pendulum, I think, back a little bit to somewhere in the middle to say, how do I measure something that I know we did the thing? So Simon mentioned having these randomized control trials to understand what the thing is that drives the outcome. And I think we need more of that to bring those evidence-based practices to light, to say these are the evidence-based practices that are going to drive that better outcome and drive that value. And sort of corollary to what you asked, I think what we've done quite a bit is we've put the measures, those quality measures, into place based on things we have data for. And those elements may not always be what are important to the patient. I think that's where we've got a big opportunity, is to bring the patient and the person that may not even be a patient yet into the conversation, to say, what's the outcome that's important to you? What's the value that's important to you, especially when the patient doesn't always have financial skin in the game. So the concept of decreased cost of care may not be relevant to the patient, but their journey in healthcare may be relevant. Their health may not even be relevant, because they may not always be thinking of the end game like the payer or the regulator might be thinking of that end game. So I'm not sure if I answered the question there, but
I thought that was an absolutely brilliant answer to a very difficult question. And there's a couple of things that I want to pick up on in that. I mean, firstly, it feels like the answer to the question of how do we go from measuring whether a thing was done to measuring how well a thing was done and what the outcome for a patient would be is slowly, so a bit at a time. So, we talked about things like that. Jane talked about visits to the ER. You mentioned readmission rates. You talked about the idea of Simon's, trial and error model of, well, if we do a thing differently, what does that change? What does it do? So actually, the mix of volume and value in terms of payer models is really about, to a degree, and please, if I've got this wrong, somebody jump in and tell me I've got this wrong, because my understanding from listening here is that we continue to a greater or lesser degree to pay for things being done, but then we incentivize and change payment models gradually based on an understanding of, actually, if we do this thing, then that increases the value to patient, and therefore it's worth more and it's worth paying a bit more for. Have I got that right? Have I understood that correctly?
Yeah, I think you did. And you're actually making me think of a question in that. And I'm curious, for the experience outside of the US, is the patient brought into that conversation? Does the patient know that they're in a value-based model, and do they have skin in the game anywhere? Because that's what I've always thought was missing, is the patient's skin in the game. Sounds punitive, but their platform, their ability to understand the incentives that the providers have and interact with that and drive their own healthcare, and maybe even be incentivized through whatever mechanism that may be. But I'm just curious, do those exist out there? Sorry, Steve, to take your...
No, please. Yeah, that's great. That's fantastic. I'm absolutely encouraged that throwing that one back into the mix. And I'm going to ask Reem and Rob and Abele that in a moment. Before I do throw it over to you, Reem, first, I will just use one little anecdote, something that I've said on stages in the US and in the Middle East before now, when being asked about the UK model, is that, I've referred to the NHS and the UK payer model as the magic money tree, because to a patient and even to a clinician in the UK, there's very little understanding of the cost of healthcare. It's very much it's paid for out of taxation. It's there. It's always there. It's not going anywhere. I go into a doctor's and I expect to be treated. And a doctor doesn't necessarily look at me and think, can I afford to treat you? And that's the kind of the effect, I guess, of the NHS system, and means that I think in this country, do people understand whether they're part of a value or volume-based payer model? They haven't got a clue. All they know is, if I'm sick, I get looked after. And that's a great place to be, certainly from my point of view as a citizen of this country. Reem, what's the patient's view of healthcare in the Middle East?
I think this is an extremely important part of our conversation, and it's half of the value equation. It's outcomes that matter the most to people. And in measuring that, and it's key for us to measure that in order for us to say that we are doing value-based care or we're a high-value health system. So it's critical to the conversation. And one of the new things that are coming to health systems around the world is measuring patient-reported experiences and patient-reported outcomes. And of course, the shift in focus on these metrics, in addition to other metrics that have been proven to be useful, is key to how we pay for it. It's key to how we provide it, and it's key to how we engage with our population. Now, patients or healthy people in the population have not classically been part of the design of these metrics. We classically collect patient-reported experiences, and we look at things like, the inpatient journey or the outpatient journey. But in this shift, and I think relevant to this conversation, is that we also have to start thinking about segmentation. So an inpatient experience is different if someone has cancer versus someone that had an appendix removed, or we need to start actually slicing it in a different way, whether it's for the provider or the payer. Jane, you mentioned the frequent flyers and the most expensive, most expensive patients in our health sectors, and slicing it based on which segment or which disease category is crucial. I mean, I'll give an example from our experience in Saudi. So we went and we looked at frequent flyers in a general hospital that is a secondary care facility in, part of our country. And I was sure I was going to bet all what I had, thinking that these frequent flyers are for sure renal failure, cardiac patients. I was sure that these were like the bad patients that were not following the care plan. We were surprised that the average age was 45 and that these were trauma victims. And they were coming frequently to the hospital because their post-hospital care was missing, because we have in our setting, we have less rehab, less intense home care. And so, I mean, clearly the intervention needs to be done in that area. And that's kind of where we have to start focusing. One more thing on patient-reported outcomes, and it's relevant to this discussion we're having on benchmarking and the importance for that. PROMs are globally a new way of measuring outcomes. PROMs are, they're surveys. They need to be delivered in a language that's local. I mean, Arabic for us, English in other countries, and also they need to be context specific and, tested for that purpose. There is a multinational project that, I know the US and the UK, everyone on the call today, your countries are participating in it. It's an OECD-led project that's called PARIS, short for Patient Reported Indicator Survey. And Saudi Arabia is also participating in it as the one Arabic-speaking country. And it's been, very interesting going into this on a global level, the experience of actually implementing it and seeing how different health systems are actually going to use this information, whether it's from a policy making or paying perspective or provider perspective or a patient beneficiary perspective. And the OECD is going to release the flagship report, which is a global benchmarking, a rare case of global benchmarking on outcomes in the first quarter of 2025, and how we're going to use it. And we're, Steve, I know you asked me this earlier. We're working with a public payer to ask that question. So now we have this data. So what? How is this going to influence how we contract with the individual clusters or health clusters, the provider unit, in providing better care or interventions on that? I'm very very passionate about this part, the conversation on measuring value.
No, it's fascinating, and it is. I'm glad you brought up the example of the transformation program in Saudi, because, as I understand it, the intention is, and for those that are watching that are not familiar with what's going on in Saudi, there is essentially the creation of a whole new public health system. The Ministry of Health has been divided up. The ministry is now regulator. Reem, correct me if any of this is wrong. The ministry is now regulator. The health holding company has been formed to create the provider arm of Saudi government healthcare, and they devolve responsibility to 21 regional clusters, ACOs, as you would understand them in the States, accountable care organisations, integrated care boards, ICBs, as we would see them in the UK, who will ultimately, as I understand it, become independent entities who bid for work essentially from the third organ of state healthcare in Saudi, the council. It's the CNHI, the Council for National.
Center for National Health Insurance.
Centre for National Health Insurance. It was going to get there eventually. It was coming, but it's interesting because, and the question around all of this, this is as a self-confessed health systems geek, Saudi fascinates me, because for years I've sat there and gone, if you could develop a brand new healthcare system from scratch in the 21st century that would be data-driven, digitally enabled, if you had money to pay for it and you didn't have too many legacy issues to worry about. I know you do have some, but you're able to kind of essentially build on a greenfield. How would you do it? And I do think when you look at the Saudi transformation program, by and large, it's early days, but it looks right. But my understanding, Rick, is that part of that transformation program will be that value-based healthcare is ostensibly mandated in the Saudi transformation. Is that correct?
That is correct. I mean, and it's the motive to create our national think tank, and it's something that all the players in the health sector are engaged in. In fact, it's the cool thing nowadays in our health sector. The providers are, even the private providers are very engaged because everyone wants to be part of this movement.
Mm-hmm. And it does mean, I think, that for all of us in the global healthcare community, Saudi is definitely somewhere that we should be engaging with, and somewhere that we should be watching. I want to come back to this point around quality and patience, because the idea of measuring quality based on numbers, based on readmission rates, based on whatever it may be, the revolutionary idea that if we want to know whether the healthcare that we're delivering is quality, why don't we ask the people that we're delivering it for? I mean, Rob, I'll come to you on this one. The cynic in me immediately says that maybe we don't always, oh, you've got cancer. No, I haven't. Can we rely on the feedback that we get from patients in order to develop payment models if, you're inevitably going to end up with the odd disgruntled individual along the way?
Yeah, it's interesting, and interesting to listen to Reem's observations as well from the Middle East one. I mean, I think there's a whole host of different factors that come into this, and I think the problems one is interesting because we've had problems ostensibly in the NHS for a number of years, and we've contractually mandated that so that providers have to do the prompts, but it's the questionnaire, Reem, isn't it? That's the issue. It's the questionnaire. It's very.
Just for those who aren't aware of it, can you just explain prompts for us?
Yeah, it's just patient-reported outcome measures. So within the NHS, contractually, there's a list of patient feedback, effectively, that the trusts or providers need to collate, and they get a certain percentage of their payment is based upon their performance and how the patient reports to it. So it's a degree of, in a very unsophisticated way, and we obviously, I think, can be a lot more sophisticated now than this. But when it started, it was quite unsophisticated, but it was a way of bringing in that patient input into, well, actually, if you're a good provider and you're getting good patient experience, then this is how we're checking to reflect that into the structure in terms of incentivizing you towards this. And one of the issues we had with that, and one of the challenges is, well, how it comes back to your point, is how do you incentivize that? And and how much do you put behind that? Because what we had was, in some areas, well, some providers didn't, it wasn't that much. And so providers didn't really follow it and weren't really bought into it and incentivized by it. And in other areas that they were looking at how it was being gamed in some ways because of the way that the system was set up. And I think I think in essence, the patient input is essential. It's a part of there's a combination, if you like, of process, outcomes, impact that you need to be incentivizing providers around to ensure that you're getting efficiency and that you're bringing that patient focus. And to take your question as well, Steve, I mean, there's a few, the classic example, I mean, we did some work on a value-based pathway for diabetes in north of England. And they had a large number of amputations of lower limbs of feet. People commonly, when you've got complications with diabetes, it can lead to issues with circulation and amputation of the feet. And they were paying, and they had very high quality services for the amputation. But actually, the people who were then paying for the service said, well, actually, this is actually a really bad outcome. This is a terrible outcome for the patients because yes, we're paying you and the service we're getting is quality, but it shouldn't be. We should be looking at managing the diabetes so that people don't need that intervention. And so looking at it from a value-based perspective, they started actually saying, well, actually, we need to invest in diabetic nurses. We need to invest in better care. And as part of the work on that system, they set up what was very affectionately called diabetic patient parties. And these weren't not parties with cake and jelly and sugar and all of those things, obviously. But we've got the patients together into a room and they started asking the patients, well, what are the important factors for you? And I think going back to your question, Steve, the thing is, you get the perspective from a lot, because what's important to somebody who's 65, who's got diabetes, who still wants to be active and do other things, as opposed to somebody who's just being diagnosed with type 1 diabetes, who's a teenager, what those patients want and what's important to them could be very, very different. And I think that's where it gets into from the healthcare system, is we need to be able to assess what's really important. So what we often find from when it comes to myself from a perspective of, well, how do we actually incentivize? What do you put into the agreement around this? It's, well, there needs to be a suite, if you like, of outcomes as to these are the factors that are important to us and these are the ones that we're prepared to put the incentivization behind. But the important thing within that, I can see Simon wants to come in here, is these agreements need to be flexible because that changes. That changes. What's important to the system and where the issues are can change. You don't have a set outcome suite that you will necessarily use for 5-10 years. It needs to be adaptable. And that's part of the collaboration between payers and providers, is if we're all incentivized, say, well, actually, this is where we need to be incentivizing things because that's where the costs come in, that's where the issues are coming with our population, then the agreements you have need to be flexible enough to allow you to shift the outcomes for that. And I think that's something which is really important to design into the implementation of the value-based approaches.
But one thing we shouldn't be doing is organising parties to feed sugar as diabetics. So I think that's probably Simon. I think you wanted to come in on this one.
One of the things that I spend a lot of my time evaluating methods of reducing the high value users. And what is fascinating, as said previously, is only 1 in 5 actually delivers the right outcome as a rule. One of the things we found absolutely essential, and echoing the previous speakers' points, is actually talking to patients. It's amazing that we had our initiative to say, try and increase medical adherence. And, our initiative was great. It looked fantastic on paper. It didn't work for certain groups of people. And when we actually talked to them, they were saying, well, actually having a phone call telling you to, collect your medicine if you can't afford the medicine is actually more annoying than anything else. And I think it is very important to proms, I think, are fantastic, but it's actually important to go beyond that, to actually talk to the patients, especially if you have an initiative that doesn't work, and find out why it doesn't work. And we try and build that into all of our studies.
It's an interesting one, actually. It's somebody on the live chat on our YouTube page, a gentleman called Robert Bergman. Thank you for your comments. Patient is the highest financial risk in value-based medicine, as well as health outcomes. Too many care plans don't take into account patient lifestyle priorities. Do we agree with that? Jane, you're the one that has the care plan. Do you too take into account patient lifestyle priorities?
Absolutely. I mean, we do quite a bit of work with not just lifestyle priorities, but understanding social determinants in our particular population and understanding what the social environment is of our particular members. We need to understand things like housing, security, transportation, access, food security or insecurity as it may be, because all of those factors, while they are, I guess they're very, we used to say they were indirect impacts on health, but I think that's not right anymore. I think we're very clear now that all of those social aspects of an individual's lifestyle have a very direct impact on their health and health outcomes. So it's very critical that we understand it. And how do we understand it? We do a lot of surveys of our own population. We do health risk assessments, and we have changed our health risk assessments to no longer be focused on just health in the classic sense. We've begun to infuse those other questions in order to get a more complete picture of what an individual's needs are, so that when we develop care plans and care coordination models, we're able to address the whole person, behavioral, physical health, but also now thinking through, do they need access to a food bank? Do they need support with rent? How do we identify community-based organizations that can help fill some of those needs? Because the thing to also remember is not all of the cost in solving some of these issues can be borne by the health system exclusively, right? We have a broader societal piggy bank to think about, and there are other resources out there. And I think directionally, there has to be some broader collaboration amongst not just health services and health systems, but also the sort of related areas, the education systems, the housing environments, the housing boards. There's a lot of work, but I think just recognizing that those non-health items are so important, I think, is the first step. And then, of course, measuring and monitoring them is the second step. And then it's, of course, making sure that we have enough resources out there to address those other gaps. That's the third one, and that's the challenge, because if you get into rural areas, for example, like in Kansas, there's just not a lot of alternative providers for things like housing if there's no housing. So you have to really grapple with true real life scenarios of there's just finite resources, and how do you deliver and how do you innovate?
I think there's a really interesting thing here, and it's when I spend a lot of time talking about a whole gamut of different issues around healthcare globally at different events around the world. Two of the, probably the three biggest themes: digital and data, value-based healthcare, and public health. And I think this is where you talk about social determinants. We're talking about value-based healthcare and incentives. I always come back to this point around, actually, how does value-based healthcare encourage us to think about public health? And when I talk about public health, I'm talking more specifically about screening programs and early identification and treatment of conditions based on good screening, but also, and in some ways even more importantly, public health messaging, smoking cessation, diet, exercise. Abele, I haven't heard from you for a while, and I'm wondering what your thoughts are on this. I mean, and I guess this is the exam question, how do we pay for public health using a value-based healthcare system? Because actually, the knock-on effect, the time it takes and the amount of measurement required to work out whether, I don't know, an ad campaign for people to get active and go and do a bit more walking to actually translate into an outcome for patients, that's a long game, isn't it?
Yeah, I want to build on something that Jane just mentioned, because I was like listening to her go, and it actually connected to, I think, which is the broader question that's cross-cutting at the global level, regional and national levels, which is really the fact that I think right now we've been talking about healthcare service delivery, and I think all of us work in the space of the system and the health system, which is inclusive of, but not just specific to, the sites of where care and service are delivered, right? It is, in fact, a cross-sector issue. And we're seeing this play out at the G20 in the fact that, again, in the wake of the pandemic, you had the establishment of the Joint Finance and Health Task Force, right? The recognition that if we're thinking about building and cultivating an ecosystem in which someone can be healthy, right, before they need care, kind of moving beyond the traditional cycle of diagnosis and treatment, into the space of prevention, into the space of the broader system that is inclusive of education, inclusive of housing, inclusive of economic mobility. I mean, even in Saudi, you look at the national level, there's the reason why the ministry invested in the establishment of a health in all policies department, right? Why? Because you're thinking about the degree to which transportation, housing, all these other variables at the preventive side of things have an incredibly massive influence on the overall health and well-being of a citizen population. Think about different population pyramids. In Saudi, you have a growing number of young people who are entering the workforce and who need to be better positioned as a healthy element of the collective vision for 2030. And then you go out to the broader level and you're thinking about it in other countries and other contexts. There's a reason why there's this growing focus. I mean, we've been in sessions with the Inter-American Development Bank or conversations with the World Economic Forum where they're actively trying to promote these ideas and to focus around the social determinants of health and health equity from an economic standpoint, right? Mm-hmm. Making the economic argument for why a prioritization in health and why an upfront investment in health actually has a ripple effect across other elements of the collective ecosystem. So this argument around why you pay, or why value, or why you're paying upfront or investing in value is one of both a health argument, but also a strategic economic investment in the overall viability of your population.
Well, it's an interesting point, isn't it? I mean, taking the example of Saudi, and Reem, you may have a comment on this. Certainly one of the conversations that I've had is the idea that, some of the investment that has taken place from the Public Investment Fund in various sort of sporting endeavours around the world, whether it's Premier League football or golf, is also about actually trying to encourage young Saudis to be more active. Now, I mean, that may or may not be the case, but at the end of the day, it is that whole thing about being joined up and thinking of health as as part of a network of measures and being at the heart of policy more generally. Simon, I want to come to you on the point that I just raised with Simon about public health. From a statistician's point of view, how easy is it to take something like a policy decision around investing in sport or an ad campaign on getting people to smoke? How is it even possible to translate that into something that could be used as part of a payer model?
It is actually remarkably hard because, of course, as a general rule, the people who take part in these initiatives are not representative of the general population, and there's all sorts of statistical trickery which I can bore people with for far too long but won't, which tries to approximate what, say, a randomized control study would actually do. And as I said, it's one thing I do find quite interesting here in the United States, that people are prepared to test things and try them for that. But I mean, there's a famous confounder of a screening program in Ireland where they were terribly proud of their screening program, and at this, they had a huge uptake in people taking part in the screening program. But it turned out that a major celebrity had died of this particular type of cancer at the very beginning of the screening program. It's impossible to disentangle the impact of the celebrity tragically dying with the actual the impact of the screening program. So statisticians and epidemiologists like myself make huge amounts of time and grants trying to evaluate these projects. It's hard, but you have to have all sorts of statistical assumptions to do that.
And this is the problem, isn't it? Because at the end of the day, we know that we require screening programs. We know that we require good public health information. But the issue in any health system is who's going to pay for it. Is that the job of government? Is that the job of insurers? I mean, Kristen, you might be able to comment on this. My understanding of the way in which public health works, and Jane, equally you may, my understanding is that you have a state level funding for public health that all insurers have to pay into. Is that right?
Jane, you may have to weigh in. I'm not sure of the flow of funds there, but I know at least in the state that I do a lot of work in Maryland, there's state public health and then there's county public health, and there's certainly cross connections between the providers and those departments of public health, because as everyone has just mentioned, those are the critical groups that can meet the patient or person that may never have been a patient yet where they are in that community. But Jane, do you know more about the flow of funds in the US and how that works?
Yeah, a little bit. I mean, there's sort of multiple piggy banks, right? And when you talk about public health, believe it or not, that is separate and apart from the, let's say, Medicaid payer piggy bank, right? So there is a set of funds that each state allocates for public health, and that is their state budget. And I think that's pretty consistent in every single state. And those are funding your local health departments, a lot of your statewide programs around certain like, get out and move campaigns or certain immunizations, all of that statewide stuff. Sometimes they will work with departments of education, and so they'll be able to collaborate in some of those ways and access, for example, kids in the public school setting. That's one set of funding. Then there's usually a county funded set of public health as well. And those are founded through taxpayer dollars within the county that those individuals reside. So what you end up having is a very uneven, right, sort of funding stream, because you can have a very wealthy county with a lot of people and a high tax base, and so they will have more dollars. Or you could have a very rural county that's sparsely populated where they just don't have a lot of resources left to them, which makes sense, right? There's less people, less dollars. You would think that there's less need. Unfortunately, that's not always the case. And we end up having some of the most needs in some of the poorer counties. But regardless, so that's a different funding stream. And then lastly, you sort of have your budget for your, say, Medicaid program for a given state. And that funding stream is based in part on taxpayer dollars, but in part on federal funds that are drawn down by states through the federal government, this is where you have organizations like in the United States, like the Centers of Medicaid and Medicare, right, who provide those additional regulatory requirements and rules and oversight. And that's really to make sure that those federal funds, which are flowing down to the state level, are sort of administered in the right way. So a lot of different, I guess, pots of money is how to look at it. And I think overall, when you get to a state, at least, you have a state legislature and you have an annual budget setting process. And this is where a lot of this is fleshed out. And I think if you were to just magnify this time 50, that's how you also have the US federal model, right? There's one budget that's ultimately created. And I think of each state as sort of like almost a mini microcosm of that.
Reem, it'd be interesting to hear how that worked in Saudi. Is public health, is screening the responsibility of the payer or the responsibility of the government?
Well, part of it is the responsibility of the payer. The private payer at the, just a word about how our sector looks like. About a third of health provision is covered by private insurers. And then 2/3 are public. And so there's MOH, the part that you explained, and then there are other government providers like, the military and university hospitals and other. And the essential benefit package that was reviewed recently by the regulator for the private sector ensured the inclusion of some public health elements. And the public payer that's emerging is also very much focused on that. Now, earlier in our conversation, we were talking about social determinants of health and other elements like promoting exercise and providing the ability for a person to go out and walk. The weather here is extremely hot. So in the months where the weather is not so hot, the ability for people to go out and walk and the encouragement, that's separate from the health payers, and it's currently part of the quality of life program. And there's a very active Ministry of Sports that's working on encouraging that, and not only encouraging that, but also funding projects and programs that enable people to engage in that. And it's measured and looked at the highest level in the government.
Useful. Do you know what? It's such a shame, but we are pretty much out of time, I'm afraid. It has been, as I expected it would be, an absolutely fascinating debate. And I want to thank all of you for being involved in this. I think the conclusions that I would draw from sitting and listening to such a fascinating conversation, first and foremost, is that value-based healthcare is more than an aspiration. It's an essential, it's a must. It's great to see that we're starting to make some progress towards. I think, Kristen, you summed it up beautifully in terms of the kind of the juxtaposition, I guess, the coexistence of volume and value-based payment models together as it sits at the moment. Feels a little bit like we're fiddling around the edges with value-based payment models, looking at ways of developing them and developing more of them. We have to reach a point at some point where all of our healthcare is paid for and judged based on value rather than based on just doing stuff and hoping for the best. So it only remains then for me to thank Professor Simon Jones, Jane Brown, Reem Bunyan, Rob McGough, Kristen Geister and Abali Anidi. It's been a fantastic session. I hope you in the audience have enjoyed it as much as I have. And I look forward to seeing you all on the next Healthcare World Series event. Thank you very much. Have a great day. Goodbye.